My charge is to speak regarding the technology today. I was, I think, the fifth employee. I've been involved with the development of the technology, the introduction of it clinically, and then now pursuing clinical investigation to develop a body of evidence, both for vertebral compression fractures as well as for treatment of spinal metastatic disease. What I'd like to do in leading into the physician lectures is give you an overview of a little bit of the innovation and our perspective and our philosophy, if you will. So we firmly believe, and our focus is to deliver targeted therapies for the treatment of vertebral pathologies. Now, this is something that really does require various core competencies. And what we've done, you'll see here, is that we feel that in order to be able to deliver targeted therapies, and you'll hear me say this throughout the day, is that we believe you need navigational instrumentation. We need to be able to deliver RF energy to tissue, and we also need to be able to provide you various and unique cement formulations that can be modified with radio frequency. So you'll see here, and again, can't point, but let's see if this works. Old habits die hard, but that's not going to work. Okay. So the thing that we like to talk quite a bit about, and I'll go through each component of our technology, is the access navigation, which is unique in the spine compared to other anatomic areas. And the ability to use radio frequency, whether we are actually delivering it to the patient to actually ablate tissue and or to the cement to modulate its viscosity and allow for longer working times using unique formulations. The RF technology platform, you'll see on your left is the stability system. In that situation, we use RF energy to increase the viscosity, allow you a very, very long working time, but at any point in time when you deliver to the patient, you have a very high viscosity and a similar viscosity over time. Again, that provides more control. And then in the STAR tumor ablation system, we're actually delivering energy through a bipolar electrode to the patient themselves. Navigational technology, we've got a core principle here where we believe the ability to navigate and articulate in bone is unique. The unique anatomy of the spine has required us to deliver or develop technology that allows you to access through the pedicle. Being transpedicular, of course, is a safer, a more predictable pattern. Many of you have used the midline osteotome. Now some of you have begun to use the power curve, which is a bit more robust and a little bit longer. And of course, the ablation instrument has been built on the same platform of articulation. So I'll talk a little bit about the VCF technology first, and one thing that those of you who know us, I see some faces, Dr. Verschaw, I know we spoke years ago. It's great to see people who have now come back and maintained some relationships. Originally, we spoke about the stability system, which is the RF-based system. We've now expanded our product offerings to provide highly viscous cement, navigational instrumentation without using RF, and also more conventional vertebroplasty. Core to all of these technologies is using this very unique vacuum mixing system, and then also we've added a handheld, as opposed to the controller delivery system, we've added a handheld delivery device which has a unique clutch to it, which allows for very precise delivery and stopping. If we think, and I'm going to spend the majority of time talking about the stability system itself, our concept here has been trying to design a technology to maximize control. And how do we do that? We like to think, given our three core competencies I was speaking about, that we can provide you control on access and cavity creation, providing the ability to access a very specific spot, create size and site-specific cavities and channels. Provide control in cement location. We do that by using RF energy and or highly viscous cement. And also we have a very unique delivery system in that we actually line our system with a Teflon-like system, which allows a more highly viscous cement to be delivered over time as opposed to clogging. And of course, being able to deliver cement from a distance up to 20 feet allows you to control your radiation exposure. If we look at the targeted access and cavity creation concept here, you can see using a navigational osteotome, a unipedicular approach. It's a more bone-sparing approach as opposed to expanding inflational devices. It allows for preferential paths to be created. What that does is it removes less bone and it creates and remains larger surface area. So when cement does enter these preferential paths, it can actually interdigitate, which provides a more near-term and a longer-term mechanical stability. If we then look at this concept, some people say, well, can you actually create cavities? So this is a cadaver study we did years ago where you can see on the left where if you have a targeted cavity creation device, you can actually make a very specific site and size specific cavity. You can see here on your left, there was an initial pass anteriorly, pulled back, made a more posterior pass, but clearly more bone is remained, and that allows for a larger surface area and interdigitation. If we look at how do we create and what's the utility of having an RF generator within our controller system, well, what that allows you to do, I'm kind of getting used to it. Thank you. Oh, 25 years of soccer, I like to hit things with my head, and I like to do things the way I've done them before, so I do apologize for that. And that was before they waterproof balls, so you can only imagine. Like I tell people, I'm not a real doctor, I'm just a veterinary surgeon, so. But what I did want to talk a little bit more specifically about how can we give you a very highly viscous cement over a long period of time. So I've been in medical device development for over 25 years. I've worked with all different kinds of cements. And the reality is that it's really cracking the Da Vinci Code. We want a highly viscous cement because that gives us control, but we want it over a long period of time. And we know that if that happens, when we get high viscosity, it no longer becomes deliverable. So what we've done here is we provide you a cement that sits on the lower left. You can see it sitting in a reservoir, which is a very long working time, a lower viscosity cement. We then have it pass through the controller, and you can see as it passes, the thin stream of cement passes through the activation element, providing variable amounts of radio frequency. What that results in is the cement on the right is the cement that's sitting in the reservoir, and the cement on the left is the cement that's now been activated, or if you will, the polymerization has been accelerated. So that allows you to have a long working time cement in your reservoir and a very highly viscous cement and the same level of viscosity over a period of time. So we have, again, expanded our product offering. Some of you have heard we've added multiple variable viscosity. So we have added more options to the multiplex controller. And you can see here there are a number of different curves. But the bottom line here on these curves, without me being able to point to them, is that you can see that for the most part, what we've done is we provide you a highly viscous cement. You can see on the left index there, the vertical index, that's viscosity in Pascal seconds. And you can see that over time, along the x-axis, what we do is we get viscosity up high, and then we allow you to deliver that over a long period of time. So you have, for the most part, the same level of viscosity when you first start as opposed to when you're doing 2, 3, 4 levels or have to start and stop. So this is a great example of how a cohesive cement can actually not only provide control, but can also provide a lifting force, and as well as a controlled interdigitation. Some people might say if it's too viscous, it won't interdigitate. So what we've done is develop this optimized model where you can see there are cylinders on both sides. On the left side, it's the viscosity of the cement prior to being delivered through radio frequency. On the right, you can see it's ultra high viscosity. Boy, talk about the power of mental thinking. This is great. I'm throwing my mind into this. So you can see what we're doing here is we're delivering cement into a closed system in the cylinder, but each cylinder has a plunger in it, and there are two small 1 millimeter defects on the left-hand side of the lower part of each of these cylinders. What's happening here is that we're going to deliver cement into both levels, and that represents, if you will, the closed system. Until we can push that plunger up above those 2 millimeter holes, it's closed. So both a lower and a higher viscosity will actually drive, because it's simply pressure, it'll drive the plunger. But once the plunger actually gets above the 2 millimeter defects, it now represents a venous system, or if you will, a vertebra with trabecular spaces, okay? So we'll look here on the left, you'll see a lower viscosity cement. On the right, the ultra high viscosity cement after RF activation. And you can see here both will in fact push the plunger up. Once the plunger on the left, once the cement drives the plunger above those 2 millimeters, you see the cement really just follow the path of least resistance. It's much more difficult to control. But on the right, a very highly viscous cement, very cohesive, actually drives that plunger. It doesn't necessarily follow the path of least resistance. Once you see 50 psi applied, there's a load cell at the top. It's going to apply some load. You'll see about 50 psi, the cement will begin to start, if you will, interdigitate. Okay, but from 300 to 600, there's no further extravasation. of cement. So what that's telling us is that a highly viscous cement can, in fact, interdigitate. It can lift and provide some lifting force, and that's been the basis of lots of height restoration work that we've seen. But also, it has a certain life to how long it will continue to extravasate. So here you can see the cement didn't even actually hit the platform once it did interdigitate, or if you will, in this optimized model, pass into the 1 millimeter defects. And this is the result of being able to create a very targeted cavity, but yet still get a lot of interdigitation, because that cement, as it comes out, once it's activated with RF energy, it's actually malleable. Okay, oftentimes, next time you do a case, think about taking a little bit of it and bouncing it on the table. Very viscous cement, if you will. Once the cement gets hard, it'll hit like a rock. If it's too fluid-like, it'll just kind of sit on the table. But if it's in that special period of polymerization, it's actually rubberized. And that's how we can actually have a very targeted cavity, a very smaller percent of the trabecular bone, where we're creating, if you will, a staging platform. The cement can then preferentially enter that space, and then as it drives, you can see here, it can actually extend well beyond that. And really the goal here is to, if you will, augment regions of compromised cancellous bones. So our goal is to give you a preferential path, allow the cement to get where it needs to go, and then allow for a more stable fracture construct to carry load from end plate to end plate. And again, you can see the interdigitation. So reduced radiation exposure, we talked a little bit about this from a control perspective. So according to inverse square law, we all understand that the further the way you are, the less radiation source that you're exposed to. As we can see here, if you actually extend the hand switch to the controller, and then the controller, the hydraulic line to the patient, you can actually be up to 20 feet away from these patients. And I've seen some physicians actually treat these patients while in the control room. But you can see here that this is Dr. Jennings at Washington University. You can see he's actually about 15 to 20 feet away from this patient. And we actually did a study in Germany where you could see that there's a remarkable reduction in the amount of radiation that a physician is exposed to when comparing delivering cement right at the table as opposed to being in this case, it was only about 10 feet away. So a remarkable reduction in radiation exposure. So I'm trained as a veterinary orthopedic surgeon, so I think about principles. We all understand that if we can understand principles and we can apply technology to principles, it'll help us navigate cases. So what we see here is that we've broken down this minimally invasive spinal augmentation procedure into certain principles, okay? And you can see here that on the left we have navigation permits control and direction of these site and size specific cavities. How do we approach that? Well, you need a mechanical advantage. A bevel tip is always helpful, as we've been using those for years to help direct. And then, so then if you look at how do we address those, you can see that the navigational osteotome really does allow for a very site and size approach and allow you to navigate to where you'd like to be. Control of cement, control and of the cement location, extravasation dependent. This is really small views. I'm going to have to look over here, guys. We can see here that later published a very interesting article. It's the Atlas of Cement Extravasation in Spine. And what he does in that particular paper, he describes the three components that control cement location. And they are fracture planes and bone morphology, the viscosity of the cement, and oddly enough, the delivery rate. We all want to go faster, but sometimes if we slow our rate and we have a more consistent rate, we can actually prohibit or minimize the degree of extravasation. And again, the concept of how does our technology address these principles, you can see here that when you add targeted cavity creations, you use RF energy to increase the viscosity and or unique cement formulations to get a very high viscosity. And then the multiplex controller actually limits, if you will, helps minimize extravasation by giving you a prescribed 1.3 millimeter, 1.3 cc's per minute rate. okay? And some of you may know Bassam Georgie. I remember years ago I was talking to him about how a slower delivery rate actually applies. And we were between cases in his two different clinics. We were driving, and he said, I get it. You're keeping me from going too fast. So I think that was interesting to find this article, and this being one of the basic principles of the clinical utility of a controller. And then, of course, cement viscosity we know is based on polymerization. So if we can, normally a native polymerization will result in a shorter working time, but if we can flatten the curve, allow you a longer working time, apply RF energy to then give you a highly viscous cement at any point in time through the case, that allows you that control. So this is just the standard indications for use and risk contraindications. They're in your book. I'm going to move on quickly to the STAR tumor ablation system so we can get to the clinical evidence. And many of you know the STAR tumor ablation system. Either you've worked with it or you've come to learn a little bit more about it. Again, you'll see the concept of targeted radiofrequency ablation using this RF generator, which allows us a real-time assessment of the ablative zone. Okay, one thing about RF energy that has always been a bit of a frustration is that it's not MR compatible, so we can't see thermal mapping. But what we can do, and it's not cryo, so we don't see the radiodensity change with the ice ball. But what we can do, now that we've added these thermocouples, we can actually real-time assess the growth of the ablation zone by measuring temperature at different locations. And of course, we've added, on the right, you'll see a navigational instrument called the SpineStar, and that actually is a bipolar device that has multiple TCs or thermocouples along its length. That was fast. Interesting. Well, this is the SpineStar itself, and what I'm going to do is focus on the lower left portion, which is the distensible electrode. You can see here that it has a bevel tip. When retracted, it can actually help you navigate. Oftentimes we use it following the use of a navigational osteotome to create a preferential path, but that bevel tip also assists in further navigation once in the vertebral body. We extend the electrode, exposing a coil. The reason we have that coil is that it disperses energy, known as an edge effect, and that active electrode, from that active electrode, energy is dumped into the tissue. You have coagulative necrosis. As the energy returns past the, and you can see here it's referred to as the insulative tip. That is a polymeric insulator, and that creates the bipolarity. The energy comes out of the active electrode on your left. It returns as quickly as it can to the ground. In this case, it's the articulating arm of the device, which is to your right. And you'll see that the ablation zone actually grows from that insulative tip, and it's an important radiographic landmark as well, because that's the center of your ablation zone, from which the zone will grow in an oblong fashion, both distally and proximally. And then you can see the proximal and distal thermocouples along the length. As that ablation zone grows, you'll see that these thermocouples will begin to increase in heat, and you can see this on the generator's monitor itself. I'll leave this to the lab. We'll talk a little bit about all the different components, but obviously you can get total RF time, and these two thermocouples are critical to assess. And the distal thermocouple is the one furthest away from your hand. So people talk about distal and proximal. We're talking about away from your hand, so it's closer to the center of the ablation zone. So you'll always see the distal thermocouple be warmer than the proximal thermocouple, okay? This thermal mapping on the left-hand side demonstrates the growth of the ablation zone. You'll see, and again, I can't point, but the insulative tip in the center portion, or the center image, that's where the zone is growing from. And on the left-hand side, you can see how that zone grows as it grows both distal and proximally. On the right-hand side, the image of the generator, you can see that the distal temperature is, in fact, warmer than the proximal, and that's because it's warming from the center of the ablation zone, both proximally and distally. Interesting, if you guys do some tumor board presentations, speak to a radiation oncologist, they love this thermal image because it reminds them of dose mapping. So it's almost, if you get your radiation oncologist and they're dozing off in the talk, show this image, because they'll kind of go, oh, that's something I recognize. And it also speaks to the dramatic temperature gradient that you see from your ablation zone to adjacent tissue. This was actually done in liver. How am I doing? It's not going to work. Yeah.
You told us, sure.
Sorry?
I don't think you can project on this.
Exactly. But I appreciate the attempt at getting more frustrated. So, well, that's an idea for a company, right? So one thing that's very important to appreciate, because we don't see ablation zones grow with radio frequency, is what are our landmarks? I've already talked to you about the unique anatomy of the spine star itself, the polymeric insulative tip, okay, or section, which is radiolucent, so you'll see that very obviously. And then what we've done is we try to work in relation to the working cannula. We can always see the end of our working cannula on imaging. So what we do is we've added 3 laser etches, and as you insert the spine star into the working cannula, you can see when you get to the first laser etch, your distal tip of the spine star is at the end of the working cannula. When you advance to the second laser etch, you now have your distal thermocouple just beyond the edge of your working cannula. So if you're thinking about where am I seeing this temperature in the body, look at the working cannula, look at your laser etchers and say, okay, if I'm at the second laser etch, I'm monitoring the temperature at the distal thermocouple. And then, of course, if you advance it, you can see that now the proximal thermocouple will be sticking out just beyond the edge of the working cannula, okay? And this is information we can give you about the specific details and working length. So procedural considerations and important landmarks. We've talked about the end of the working cannula on the right. You can see that arrow pointing to the end of the working cannula. Remember, the arrowhead is the insulative tip. That's a radiolucent portion, so that's the center of your ablation zone. And of course, you can see how you can not only on the lateral but also on the AP know where exactly is your ablation zone going to start growing from. Okay, now this isn't working. There we go. So we have 2 configurations and actually now 2 lengths of spine star. The 2 configurations to think about are, where are the thermocouples? So if you think about it, what we're trying to do is give you control, right? We've talked about that. And the way you get control is by knowing what your temperatures are, so you know the size of your ablation zone. There are other technologies out there that basically turn it on and you just pray for rain. They tell you in the manual what it's supposed to be, and you just take it for granted. What we've done is we put these thermocouples to give you more assuredness that you are actually getting an ablative temperature, given tissue densities, given heat sinks, et cetera. You know, we have the same tables in our IFUs as well, but the reality is using the thermocouples is extremely important. So what we've done here is we've added thermocouples on one configuration where the thermocouple is on the upper one. We call it the Spine Star 510. Those numbers are refer to the location of the thermocouples from the distance of the center of the ablation zone. So the insulative tip is the center of the ablation zone. 5 and 10 means you've got thermocouples 5 millimeters from the center of the ablation zone and 10 millimeters from the center of the ablation zone. The 10-15 spine star has thermocouples 10 millimeters and 15 millimeters from the ablation zone. So that means that we're only measuring half of that ablation zone, so you double that number. So for example, on the upper one, you can see that when the distal TC, which is at 5 millimeters from the center of the ablation zone, that gives you a 1 centimeter by about 0.75 centimeter ablation zone. When you reach the 10 millimeter ablation zone, you have approximately 2 centimeters by 1.5 centimeters. RF energy and RF ablative technologies, and many of you use RF in other tissues, you're familiar with the fact that it's routinely an oblong shape. Okay, so what we found is that in thousands of cadaver in vivo and benchtop testing, that we have a very consistent ablative zone morphology, and it's 3 times as long as it is 2 times wide. So you can see these numbers here as I go forward, that routinely you'll see that 3-to-2 ratio, and here in the 10-15, you'll see that the size of the ablation zone in the 10 millimeter TC is the same, whether it's in the smaller configuration or the 510 or the 10-15. And then here, as we continue to grow to the 15 millimeter TC, you can see that creates a 3 centimeter long lesion by 2 centimeter wide. And again, this is just to remind you that, in fact, the TCs, the location of the thermocouple measures half the length of the ablation zone, so just double that. And because the electrode extends 10 millimeters from the center of the ablation zone, from that insulative tip, you have to realize that when you get to 15 millimeter TC, on the proximal side of this, it's actually going to extend just a little bit beyond the end of the active electrode. So that's just something to keep in mind as you're preoperatively and intraoperatively planning. We've seen patients that benefit from this really are ones that have either met their maximum tolerable dose, they can't lie on the table, they don't want to stop chemotherapeutic protocols. I think there are a couple of cases that we'll hear about today where patients were able to be treated because with an ablative technology when they were not able to be exposed to ionizing radiation. Of course, patients that are of some myelosuppression concern. The START study, very briefly, I'm just going to run through these just so you know. We are extremely committed to developing a body of evidence. Metastatic, or if you will, ablative therapies for metastatic spinal disease is something that's been reported by Getz and Kallstrom and Dupuy over the years, but it's not necessarily for spine. If you look at those papers, there are very few spine lesions there. Monk in Vancouver, et cetera, fairly local to here, there have been some papers, but not very many have focused on spine ablation. So because of the unique anatomy and because of the unique technology, we've actually committed to doing a very large study that's evaluating TRFA, we call targeted radiofrequency ablation, for patients that have either had radiation therapy or are radiation naive. The way this study actually rolls out is we're looking at patients that have a pain score of 4 or greater, have on cross-sectional imaging, have a pathologic or have a pathologic lesion, metastatic lesion, and then whether they've received RT or not. This is stratified, not a randomized study. So we're taking patients that have either had prior RT or are naive, but all of the patients are being treated with TRFA and augmentation, and then we're following the patients up out through 6 months. Our primary endpoint is going to be pain and at 6 weeks. So we're going to follow the patients out 6 months. We are looking at serial cross-sectional imaging to look at tumor control. It's not an endpoint, but this is it's important when you're speaking to your radiation oncologist that they understand we are committed to doing the type of research to say we may, or more than likely we're adjunctive, but we're looking at in what patients could ablative therapy actually provide some time frame to a patient that they may or may not have to undergo radiation therapy, or if they are unable to, there is an alternative for them. The START sites are throughout the United States. We're lucky to have some of the investigators here. Dr. Carlisle and Dr. Lecht are both investigators in our START trial, and we're also, and there's a smattering of large academic institutions. Siteman Cancer Center, for example, at WashU is one of them, and we have private practice, as Dr. Carlisle is. So we've got a broad range of investigators and sites. We are also doing a registry, and this is something we're very committed to. We hope to enroll close to 1,000 patients. It's a prospective registry. These are all on-label studies. Where anyone who's interested in participating, please contact me. And we're basically looking at patients with painful spinal metastatic lesions in the thoracolumbar spine, which is what we're indicated for. The outcomes are going to be pain, function, quality of life. I should tell you, we are using quality of life measures and validated clinical instruments that are used by oncologists. And we're doing that because our goal is not to publish in interventional journals or procedural journals, where our goal is to actually publish in oncology journals. So when these oncologists come back from their meetings, they come to you and they say, by the way, do you do this interventional procedure? So that's the goal, because that's really going to be the body of evidence that's required to push this into a more common standard of care, where our goal is to get into the NCCN guidelines and various societal guidelines for many purposes. One is to maintain reimbursement and then to drive reimbursement. And we're going to follow these patients out to on a quarterly basis out to 1 or 2 years. So there are 2 different types of programs: the START trial, which is the more in-depth trial, and then the STAR registry, which is a more open trial. And this is the indication for use with the risk and contraindications. And with that, I'll thank you very much for the time and the attention. I know it's been quick. I hope I've provided you some basis upon which we can now speak to the clinical procedure, technology, and clinical evidence that we're in the process of developing.